and also surgery department head of uh, running on Institute of Medical Sciences. So, Professor Ghosh, we can start.
Okay, thank you, Professor Saha. And let me share this. Is this slides visible?
Yes, yes.
So good morning, everybody. Now the topic is the pyogenic liver abscess. In fact, this topic is important from mostly the theoretical point of view, because in theory you might have questions, long questions or problem-oriented questions from this topic. And also during oral and practical examination or OSCE types, you might have to identify the CT scan PRETs in which maybe one of the diagnoses will be pyogenic liver abscess, and you might have some questions on this topic. However, this topic is it's not a very elaborate topic; it's very specific, and I have hardly 10 slides on this topic. But at the same time, I see that iambic liver abscess is one of the important differential diagnosis of this pyogenic liver abscess. So I have combined the iambic liver abscess along with this pyogenic liver abscess. I don't know whether you have separate classes on iambic liver abscess or not, but I want to highlight some of the slides on iambic liver abscess. But even if you have another class on iambic liver abscess, it doesn't matter. So repetition is good. That helps you to understand and retain the knowledge, whatever you have from today's class. So let's talk about this pyogenic liver abscess. And by definition, it's a localized collection of pus in the liver parenchyma caused by bacterial infection. So this is a bacterial infection, and iambic liver abscess, as you know, is amoeba is there's a other kind of infection. So historical context is that it is often caused by previously the appendicitis was one of the commonest cause of this pyogenic liver abscess, now most frequently associated with biliary tract disease, particularly in various kinds of cholangitic abscess or infection of the biliary tree, uh, cholangitis. So these are the common causes of pyogenic liver abscess, and it is actually a very emergency and maybe a life threatening if it's not detected early and treated early. But however, if it is detected and treated early with drainage and antibiotics, it has got excellent prognosis. So how the bacteria reaches the liver? Basically, it's a biliary tract from where the ascending cholangitis or due to acute cholecystitis or say for other malignancies. So it can reach from the biliary tree to the uh, liver through the intrahepatic biliary radicals, and maybe by vena it can spread by venous route, that is pylophlebitis, from any infective focus in the large intestines particularly, or through the hepatic artery hematogenous spread from the distant sides from like endocarditis, or may have direct extension from the adjacent infections like subphrenic abscess or empyema gallbladder. So these are the situations where it can have a direct extensions. And of course, if any kind of trauma, particularly the penetrating trauma or blunt trauma, can give rise to liver abscess. So microbiologically, the most common causative organisms are gram-negative organism, of course, and as the E. coli is the commonest organism or infective or invasive organism in the intestine. So E. coli, Klebsiella pneumoniae. So these are the commonest gram-negative organisms. And of the gram-positive organisms, Staphylococcus aureus or Streptococcus can also produce pyogenic liver abscess. And most of the time these are this thing polymicrobial infections. So bacteria are supposed found among this liver abscess. So clinical features, the classical triad is fever, jaundice, and right upper quadrant pain. And but however, this classical triad seems only in 10 to 30% of cases. Jaundice may be a late presentations. And on general symptoms, malaise, anorexia, weight loss, night sweats. So these are all general symptoms that obviously are quite vague and not very specific to pyogenic liver abscess. However, on physical examination, we might find the liver is slightly enlarged and there is tenderness over the right upper quadrant and occasionally right-sided pleural effusion. And also we can percuss over the intercostal space on the right sides. So there will be a tenderness, and sometimes you can find on pressure over the intercostal spaces, the patient will have uh, typical tenderness. So these are more typical signs of liver abscess. So any liver abscess could be iambic liver abscess, could be pyogenic liver abscess. And for investigations, of course, on complete hemogram, we will find that the patient is having leukocytosis and elevated alkaline phosphatase, and other liver function test may be deranged. And on blood culture, positive organism found only in 50% of cases. So most diagnostic test for this is, of course, initially we should start with the ultrasonography of the abdomen, and this ultrasonography will show can clearly show the hypoechoic lesion in the liver, along with the other features like pleural effusion in the on the right side that can also be diagnosed on ultrasonography. There might be slight hepatomegaly as well. However, on CT scan, which is the gold standard, we can also see the actual lesion. So in CT scan, you can see here. So this is a typical CT scan features of pictures of liver abscess, pyogenic liver abscess. So you can see the multiple hypo uh, attenuated lesions in the CT scan. So these are all typical of iambic liver abscess. So here you can see there is multiple liver abscesses. So it provides a detail on the size, number, and location of the abscess. So once diagnosis of liver abscess is confirmed by biochemical investigations as well as imaging. So next step is to start the treatment of this patient. The management principles in depends on the triple pillar approach, that is antibiotic therapy, drainage, and surgical drainage, and minimal invasive procedures with drainage and surgical drainage if required. So antibiotic therapy should start with the broad spectrum intravenous coverage, then narrow the antibiotic spectrum on the basis of culture results. So usually the antibiotic therapy should be continued for 4 weeks, minimum 4 weeks, and maybe extended up to 6 weeks total. And along with that, the drainage is essential. So percutaneous needle aspiration by ultrasonography guided, that is very, very effective. And this is usually employed for the small abscess or multiple abscesses. However, if the large abscess, which happens in some cases, particularly patients who are diabetic or who are having other immunosuppressions, or very neglected cases, alcoholic patients, so the presence with a very large abscess. So in such situations, US guided percutaneous catheter drainage is very, very useful and is a minimal invasive. And if sometimes these are multiloculated, and if the it ruptures, perhaps the percutaneous catheter drainage may not work properly. So in such situations, and the conditions of the patient deteriorates, so we'll have to think about the surgical drainage. And surgical drainage means that we might need to have exploratory laparotomy and do the drainage and patron toileting in case of rupture of the abscess. So these are the standard treatment for the pyogenic liver abscess, and of course complications can occur. Uh, the most dreaded complication is rupture of the abscess. So it can rupture into the surrounding, either in the peritoneal cavity or in the pleural space. Even it can rupture in the pleural space, particularly when the abscess situated in the right lobe of the liver, in the in either segment 6 or 7, is very close to the pleural cavity, so that it can rupture into the pleural cavity, and thereby patient can have respiratory distress. Even patient can go into shock and sepsis. So ophthalmitis, particularly associated with Klebsiella and hepatobronchial fistula. So these are all complications, rare complications, particularly in neglected patient or patients with immunocompromised states. So, however, all this, in case of these complications, patient may need exploratory laparotomy, immediate attention, exploratory laparotomy, and toileting, drainage of the abscess, and wide spectrum antibiotic coverage and other supporting measures as required, because otherwise the prognosis is very good. So in short, this is about the pyogenic liver abscess, and there are many similarities between the pyogenic liver abscess and amoebic liver abscess. So I thought that it would be useful if I club these two conditions together. So if we talk about the amoebic liver abscess, it is the most common extraintestinal manifestation of the infection of Entamoeba histolytica. So as you know, the amoebic liver abscess is caused by Entamoeba histolytica. It's common in this part of the country, our part of the country, and so if you get a patient with liver abscess, so think the possibility of the amoebic liver abscess as well, and again significant morbidity if it's left untreated. So in India, as I said, is a common in other parts of the world, particularly Mexico, South America, in the low socioeconomic zones. Rather, I mean, bad hygiene is one of the reason for this disease. Male are more commonly affected than the females, and it's a middle-aged persons are mostly affected. So again, risk factors is same as pyogenic liver abscess, that is alcoholism, malnutrition, poor sanitation, immunosuppressions, diabetic patient, tubercular patient, or patient having other form of immunosuppressions, they are at risk for developing this amoebic liver abscess. So if you look into the life cycle of the Entamoeba histolytica, so it is a fecal-oral contamination. So the Entamoeba histolytica enters our body through the oral route, and in the oral route it enters as a mature cyst, and then when it so it comes to the mature when it
Hey, Lakshmi Agniti, please mute.
so when
बोल दे तू
when it enters into the colon, this excitation occurs, and the stropozoid migrates into the large intestine, and they trophozoite then multiply by binary fission. So they multiply here and they invade the intestinal mucosa. So here they invade the intestinal mucosa, and from there they through the bloodstream the infecting sites as such as the liver or brain or lungs, they then settle in the liver or may into the lungs or in the brain. So this is the life cycle of Entamoeba histolytica, and it can settle into the portal circulation and then comes to the liver. When it reaches the liver via portal vein, the cytotoxic effects that occurs, and that causes induction of apoptosis, and cysteine proteinase cause the lysis of the hepatocytes and resulting in the liquefactive necrosis that is known as ANCOVIS or SPAS. So this is a very typical term that is used for amoebic liver abscess, and typically this pus is sterile and there is no bacteria in. So this can be also when we do percutaneous catheter drainage or aspirate. So looking at the color of the pus, so you can reasonably certain that this is a patient of amoebic liver abscess. So usually is a solitary and is found on the right of the liver, right lobe of the liver in 80% of the cases. Why right lobe of the liver? Because in portal vein flow, the portal venous flow is more preferential to the right lobe because of the distribution of the right and left portal vein. In fact, the left portal vein is more at right angle to the main portal vein than the right portal vein. So the blood flows more preferentially into the right lobe of the liver. So that's why right lobe of the liver are more commonly affected in iambic liver abscess or the pyogenic liver abscess as well. So subcapsular location is very common, and this is the reason why it gets adhered with the pleural cavity into the pleura and chances of rupture in the pleural space. So these are usually round or oval lesions, and no true pyogenic membrane is seen, and chocolate brown thick fluid, that is anchovy pus, that is the characteristics of this amoebic liver abscess. So clinical features, symptoms and signs are more or less similar with the pyogenic liver abscess. Same thing: fever, right upper quadrant pain, anorexia, weight loss, malaise, and signs tender hepatomegaly, intercostal tenderness, trial effusion. So I mean, same as the pyogenic liver abscess. So complications are also similar. It can rupture into interperitoneal, pleural space or pericardial space, but rare. But if it's so, it's very fatal. Secondary bacterial infection is common, and inferior vena cava thrombosis can also occur. It can also metastasize into the brain, but of course this is rare. So differential diagnosis again is pyogenic liver abscess. Hydatids is one of the common, because the abscess, particularly if the hydatids is infected hydatids, hepatocellular carcinoma can mimic, or the other way around also. Pyogenic liver abscess or iambic liver abscess can mimic hepatocellular carcinoma, and tubercular liver abscess is another differential diagnosis. So the investigations, again, there will be leukocytosis as because there's an infection, elevated ESR, mildly elevated alkaline phosphatase, mild transaminitis, because there is, of course, there is a little bit of hepatitis, and on serology, anti-iambic antibodies are very sensitive. More than 90% cases it will be sensitive. Stool examination often negative for iambic liver abscess. So back the histolytic may not be parasite may not be found in the stool examination. On imaging, the typical lesions, ultrasonography will show the hypoechoic lesion, round or oval, and low level of internal echoes. More or less, ultrasonography is diagnostic, but to be more confirmed, CCT abdomen is usually recommended. There is hypodense or hypoattenuated lesions, and there will be peripheral rim enhancement. That is typical sign. So this is the peripheral rim enhancement and double target sign. So what does it mean? The central hypodense abscess cavity means that is the abscess cavity and inner enhancing membrane, that is hyperdense ring. So this will be there, an outer hypo enhancing zone, which signifies that there is edema around the abscess cavity. So there will be hypo enhancing zone of edema. So all these are very typical features of iambic liver abscess. So treatment is same as the pyogenic liver abscess. Thick chocolate brown pus can be aspirated. It is odorless, sterile on culture, and trophozoites are rarely seen. So we can hardly culture the trophozoite from the uh, pus, aspirated pus. So indication for aspiration is particularly when if it's a left lobe abscess, if it is a larger than 5 centimeter and is threatening to be ruptured, and it does not respond to the medical therapy. So then aspiration can be done. Medical management include the treatment with the metronidazole, that is the mainstay of the treatment and should be given at the maximum possible doses as per the body weight. So 750 milligram thrice daily into 7 to 10 days is a standard recommended dose. And along with that, we also give a broad spectrum antibiotic usually. Alternatively, tindazole, ondazole, or any luminal agent or diloxanide fluoride. So this can be the standard anti-amoebic treatment at the present day. Interventional management is required when the medical therapy fails or in case of large abscesses. So USG guided percutaneous needle aspiration, same as the pyogenic liver abscess, optical catheter drainage, or rarely the open surgical drainage is indicated. So open surgical drainage is indicated when the abscess is very large, there is thin rim of liver tissue when we can see that means that there is a impending rupture. Persistent fever after 72 to 96 hours, that means in spite of the antibiotic therapy, patient does not respond. Patient is having still fever and pain. So this so means that it's not responding to the antibiotic therapy, or if there is lateral abscess. So in such situations, we might have to think about the open surgical drainage. So if we compare both the things, amoebic liver abscess and pyogenic liver abscess, so in pyogenic, amoebic liver abscess, it is the entamoeba histolytica, the parasites, whereas in pyogenic liver abscess, it is the bacteria. Most of the time, it is a polymicrobial. That means more number of bacteria are present. Usually solitary amoebic liver abscess, but pyogenic liver abscess tend to be multiple. Pus color is anchoviscous in amoebic liver abscess, but in pyogenic liver abscess, it is purulent. Amoebic liver abscess on culture, usually sterile, no bacteria is present, but pyogenic liver abscess, of course, will have the bacteria. On culture and sensitivity and treatment, mainstay of treatment is metronidazole and amoebic liver abscess, but in pyogenic liver abscess, antibiotic and drainage is required majority of the times. So this is a pictorial depiction of the amoebic liver abscess and pyogenic liver abscess. So pyogenic liver abscess usually caused by either E. coli and Klebsiella, usually polymicrobial infections, whereas amoebic liver abscess is caused by Entamoeba histolytica. So prognosis, because it's an infection, so expected to have excellent prognosis. But if untreated, the mortality is less than 5%, but should be treated properly, and high mortality if the abscess is ruptured, particularly in the pleural space. So these are a few recent advances regarding the management of amoebic liver abscess. It can also be detected by the PCR-based various tests. Antigen detection assays can be employed to differentiate between pyogenic liver abscess and amoebic liver abscess. And minimally invasive drainage technique like aspiration or percutaneous catheter drainage can be employed to treat these abscesses. So the take-home message would be the most common extraintestinal IMBSis manifestation, and right lobe solitary lesions are typical findings of amoebic liver abscess. Serology is highly sensitive and reliable. Metronidazole is the mainstay of treatment, and drain when it is indicated. So basically, these two topics are very similar, and if you read it together, I think uh, it will be easy for you to remember things, and either in theory you can expect to have questions on this topic, or during practical examination, particularly on CT scan, or maybe during frank oral, you may encounter this topic, and I think if you read it well, there will be no problem in answering these questions. So thank you very much. If you have any questions, I'm happy to answer.
Thank you, Professor Ghosh. It's a nice comprehensive coverage of both pyogenic liver abscess and amoebic liver abscess. And often these are situations is very difficult sometimes to differentiate between the pyogenic and the amoebic liver abscess. The points Dr. Ghosh has already mentioned. And another important clinical pointer is patient with pyogenic liver abscess are more critically ill. They are more toxic than iambic liver abscess patients.
Absolutely.
So, if you have any question, but if you see in the theory examination, this is the pattern you should follow. It will be only 10 marks question, so it will not give so much of information also. But at least you should touch the basic points, how to describe a pyogenic or a iambic liver abscess. So, if there is no question, you can conclude.
Right. So in theory, examiner will like to see whether you have touched upon the main things, right? There is no point keeping writing stories. So if you just make a headlines and then give the descriptions, I think examiner will be happy to give you very good marks, right? So make it a practice, and if you just read couple of times, I think it's not very difficult, easy to remember, and you can expect to have good marks on this.
Thank you, Dr. Ghosh. Thank you very much.
Thank you, Professor.
Thank you. So please continue with this program. Okay. Thank you.